Our next speaker is Nasibeh Farahani from the Mayo Clinic. She's going to take questions at the end, so if you would reserve time and hold your questions until the talk concludes. And so without further ado, let's give a warm welcome for Dr. Farahani.
Okay, thanks for having me. This is Nasibeh. I'm an assistant professor of medicine by research. I'm wearing different hats. I'm a manager working with the startup companies in Mayo Clinic platform. If you want to learn more, just come to me after the meeting. This is my QR code, specifically for the people who are online. I would love to have your questions. Always questions has helped me to learn more and more about our caveats and blind spot. Okay, I have mentored over 60 companies so far in less than 3 years for their AI solution development. And the main concerns currently is responsible AI. The work sounds like to be very big, but honestly it's not scary at all. So today I'm going to help you to understand a little bit more. For some reason it's like, hold on, I have some technical difficulties. I don't see my cursor. Okay, so I have mentored over, I think it's getting better. Okay, works. Perfect, thank you so much. So for today, I'm talking about how to operationalize responsible AI. You can search in the Google, learn more about trustworthy AI, but I'm talking about operation, how to maybe bring it to practice, and how to use it in healthcare. For healthcare, it's very important how to do that and how to do it responsibly. Before getting that started, I want to introduce you Dr. Berker. Dr. Berker is a doctor robot. He's kind, he's very nice, but the only issue that he has, he only has seen sick boys. How many of you, your husband or your boyfriend, partner gets sick, get cold, and I'm dying, Literally that kind of robot. And he has just seen doctor, kind of boys. He's a good robot, actually, but if you see a girl or others would say, you're fine. Because for us women, 10, when we say 10 as a pain, means giving birth. For men, 10 is getting cold and coughing. So what's the issue here? Dr. Berker is a good doctor robot, but just misses good data from women. Women have good data. So today I'm going to talk a little bit about responsible AI as a definition and why performance disparity in healthcare matter for us first. Then I talk about different types of biases for the people who are kind of developing AI, and they need to be mindful of that, and their impact on why it is important and what is the impact on patient care. Then we talk about AI lifecycle a little bit, and after that, leaders, whoever is in this room, either you are developing an AI, you are a student, you are, I don't know, chair of department, in some level you get engaged in that. So that leadership perspective, what you should do next, and some minor questions, how we regulate AI, and I have a bonus. I have developed an AI echo button in my past life. I'm a hands-on solution developer by experience. I can just review that case for you very fast to see how the journey may look like as a use case. Okay, responsible AI. The word sounds like to be very scary. I'm a parent, like responsible parent. You heard about that. But simply, I should say it means being a good data scientist, a good leader in different levels, in design, development, and implementation. And just looking into the details, be more detail-oriented in general. So beyond being a trend that everyone is talking about that, it's a commitment. It's more for transparency, equity, and security. So it's not just being great, be 100% great. It means that those little girls that get cold, they need to be also diagnosed. So a responsible approach always ensures AI that technically they are efficient and aligned with human values. because AI is here to help us 100%, not 50%. And this means that creating models that they are away from biases, or we know about their biases. So biases is everywhere. Just having to know, knowing more about that is very helpful. Okay, why understanding this performance disparity in AI matters, specifically in healthcare? Because you give uneven care quality. You know, half of the patients for Dr. Berker won't be diagnosed, and that's the threat for the society. That's a threat for me as a woman and others who are not diagnosed with AI. And unfortunately, the people who are in rural areas, elders, and underdeserved or minorities are in threat more than others because they are seen less than others in the data set. And unfortunately, AI is mainly focusing on majority. So it is important because it helps your clinical decision support system become equitable. And what is the importance? Why it impacts patient care? It helps them to, if you don't take care of that, delayed care happens for some groups, under referral happens, and patient trust will be lost. Just imagine Dr. Berker, no girls want to meet him because he always says, you are fine. So you need to always be mindful. Patients need to have trust on AI, and patients are your source of information. They are your customers at this first time you make money. Okay, I understand that money making. But if you lose that trust, you lose your AI too. Going back to the sources of AI bias, we have 3 sections: data, algorithms, and deployment or presentation. And I'm going to bring more examples so you can get connected to that. So each one need to be addressed when you are developing, deploying, or using that AI in any stage. So it's not just one touch point that you develop an AI and you go. No, the data need to be complete. Algorithms need to make sure that they understand and don't amplify the biasness. And at the same time, this representation need to be interpreted in a good way so the user bias won't be added to that bias. Let me give you more example. Going back to Dr. Berker, what happens? Okay, the first thing, data bias, sick boys. Only trained on sick boys. Symptoms in girl are not present in his data set when he was trained. Algorithmic bias is doctor just look at the frequency of visits. For my husband, when he gets sick 10 times a day, he calls nurse triage, I'm dying. For me, I just take 3 ibuprofen and I work. So if you are just counting the encounters, definitely that's not a good sign to show a person is sick. So thinks that the boys are sicker because they call more and they visit more. And presentation button, there is a that's a design issue. There is a flashy red alert without no context. Sees the boys, beep, 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 sick, girls, no impression. So doctor just overtrusts the system. Sick, no sick, sick, no sick, no explanation. Let's go back to AI lifecycle and see where we can mitigate this bias. As I mentioned, we have design stage, we have develop stage, and we have deploy stage. In each of them, you need to be mindful of biases. You always need to observe the system. AI is a mini brain. This mini brain need to be observed carefully, how they make decisions. You need to have different levels of dashboard to know what happens. If it is data, you need to see the data and see how many patients were boys, girls, and others, and see how the model was trained. Was it 50-50, 10%, I don't know, 90, or another combinations, and how the model was trained. You need to have full visibility of that. The second one is during development. During development, AI scientists, clinicians, whoever that is engaged need to know how this model is developed. We call it explainable, if you want to learn more about that. They need to get connected. Physicians, they have protocols. They need to make sure that those protocols are seen in their kind of modeling or so. And the last one is deployment. Usually people miss this step. When they create a model, they put it on practice, go for it. No, you need to always rare cases, when things go wrong, need to be reported back to the group, and they need to go back and fine-tune the model. And I'm going to provide you an example at the end so you get connected what I mean by that. So let's go back to the AI lifecycle and see how we can address those risks. First of all, if the data is underrepresented or overrepresented, you need to make sure that you mitigate that, or you have some plan. For example, in Mayo Clinic platform, we have over 20 years of data at Mayo Clinic. Maybe you need to curate a data set in a way that you have, 40% women, 50 men and 10% others, whatever. You need to define or at least curate the data in a good way. And make sure if the model during the model development, even the answers are skewed, you need to have some perspective into that. And later, the calibrations need to happen during the deployment, and feedback loop. 100 times, I'm telling you, the feedback loop is such an important thing. Any question, no question is a bad question when you are working in the AI. You need to have a curious mind. Always consider AI is like a 9-year-old kid. They feel like they know everything, but they are the scariest creature in the world. Sometimes my son do something, I say, how you did this? I feel like that's okay. Because they are lacking experience, because if they were not, they haven't seen what can happen when you burn a house. So simply keep in mind, 9-year-old. With that mindset, you can kind of ask more questions. Okay, how to mitigate those? Diverse representation of data set. Minimum thing is race, gender, geography, and socioeconomic status. These are the minimum. These are the minimum. You need to go beyond that. If it is a heart disease, you need to have different shapes of heart. You need to have different BMIs. You need to have, but these are the minimums. At least these minimums need to happen. You need to have a diverse perspective when you are developing your model. I was such a blessed person that for my AI developments, I always had a clinician, several technicians, AI solution developers, and even people like patient advocates. They reviewed for me my AIs, and they were always asking me questions. Even craziest, when the questions are the hardest and you are very uncomfortable, that's the exact moment that trustworthy AI comes to, to fruition. Those questions, I said, this is such a crazy model. Exactly, that's the moment that you need to go and see why this patient feel like that's a crazy model, or why that sonographer feel like that your model doesn't make sense. So also you need to have different metrics for subgroups. At least how much is the accuracy for this subgroup. We always say accuracy. Okay, accuracy for subgroups matters. Maybe then, can identify cold for, people who are, for boys, 100%, for girls, 50%. That's something you need to bring to your attention. And during the deployment, you need to train your end user. Sometimes, my son knows much better than me about my iPhone. They are so good. You need to train your users. Don't feel like because I don't know, I have a college degree or I have a PhD, it means that I know everything. Maybe you developed it, you played with that whole your life. How long? 2 years, 3 years? I don't know it. I just pushed this button. Maybe I'm pushing that in the wrong time. Maybe I need to push it and have some interpretation. So always train your people and try to accommodate for that risk. And feedback loop, real-time monitoring is everything. You need to have this black box that we are talking about, that if it is black box, that's a threat. Okay, you cannot solve the black box, at least give feedback. Okay, the patient was diagnosed. The patient comes back and says, that was a wrong diagnosis. Give the feedback to the physician. Your AI made mistake. Your AI is not good. That's the feedback. And this feedback needs to be hauled the way back to the AI solution developer and make it better. Okay, let's go back to Mr. Berker. We know he's not fair. What we are going to do, let's add more girls to the cohort for the AI development. We are going to retrain his model, add more girls, okay, and more others from different ages, genders, sizes. We want to make sure that the data is complete or semi-complete. Biasness is always there. The second one is look at real symptoms. Encounter is not a good one. Okay, I don't know, do they have a coughing, fever? A lot of different kinds of symptoms need to be added. During the deployment, what should we do? Adjust based on clinic locations. For Minnesota, 68 is great, right? For Arizona, 75 is cold, right? So you need to adjust based on location. Different people in different locations, they get adjusted based on their climate or so. And you need to make sure you are aware of even their geographic location. But based on your use case, I'm oversimplifying those cases right now. And another thing is you need to make sure that everything is double-checked. Double-checked means you have a feedback loop. And when things go wrong, when we make mistakes, you need to make sure you report the problems. And you go back and retrain that. That retraining is very costly. That retraining is very expensive, actually. But that's where miracle happens. And rarely it's left out because we are still too early in AI journey. Okay, let's update Dr. Berker to Dr. Berker 2.0. Let's call him Dr. Berker now. He's trained in all gender with different backgrounds, recognize diverse, kind of patterns, explains why this patient is sick, not encounters, number of encounters, number of visits is not that. I don't know, I saw sour, kind of throat or, sore throat or beyond that. Also explains, patient likes him. Patient just gives, good, 5 out of 5, 4 out of 5. You have the feedback loop. So patient trusts him, so it sounds like he's doing a good job. Okay, this is mainly for you leaders, for the people who feel like trustworthy AI and responsible AI is a waste of time. It's not a waste of time. Look at here. Diagnosis accuracy bumped into 90 from 72. Before, 1 out of 4 patients, the ratio definitely girls go less than boys to the clinic. So what was misdiagnosed currently is 1 out of 10. So annual cost of error was $4 million. Currently, reduced, so you make money. So there is some saving, but it's in, probably you see it later. And patient trust AI, they embrace the AI, they come back, use the AI, and they don't ask for doctor visit, in-person doctor visit, return in investment 3 times more, and overall, the all score of biasness is much, much less, so helps us to have a better AI. Okay, we are upgraded, we are good. What happens next? I'm not an AI developer. I'm not a hands-on person. How I can help? I'm in a leadership positions. I have a lab, and my students are developing AI. What should I do? Just get engaged, simple, get engaged. AI can help to reduce disparity, but at the same time, unfortunately, mainly focus on majority. So act in every stage. Be the person that try to bring more reviews. Have a review committee, bi-weekly. Meet with your students and review that. Ask nonsense questions, challenge them. And this missing part, community engagement, I still haven't seen so much of that. I attended a conference, it names is Health. It's a startup company kind of gathering. And we had a launch this year, patient launch, and we have patient advocates. Go see your patients. If I go back in my AI button journey that I'm going to explain in a minute about that, I wish that I have seen my patients earlier. When you feel the pain, when you sit down, now this data, this 2D data become 3D for you. You are not creating an AI. You are helping a patient. You see the pain. When you know what happens, the patient goes through those shocks and how much pain, you will be more mindful. And champion equity. Okay, for leaders, we need cross-functional team. If you have a team that is developing AI solution, you just don't need one programmer. You need one clinician or at least someone with the background, and that's what I do with my startups. if I don't see the programmer and clinician working together, we never let them use our data and say this is the wrong route. We need ethicists, we need patient advocates. I'm hoping more patient advocates could be added. Try to have more protocols for biasness, minimum, like at least something that some AI tools like minimum, gender need to be reported, race need to be reported, location need to be reported, at least some safeguards. Make sure that you monitor AI performance with different tools. With generative AI, currently bringing up a dashboard doesn't take so much long, so please use that. Make sure it is explainable. It tells, visit count. It's a kind of explanation, visit count, like it's explanation, but try to, black box, yes, majority of deep neural networks, there are black box, but make sure that you have some explainability for your models. And make sure that this training and learning, that's a mutual experience. Every month, see the sonographers, users, technicians, lab scientists who are using this AI, and be mindful of their feedback. Again, engage patients and try to work with external. Sometimes because we are so fine-tuned to our own community, we forget about our blind spots. Okay, I know majority of you who are here, you are students, you are already working on some AI development. If you are developing already a regression model, you are an AI solution developer in my mind. Okay, we have some technical resources. CHAI, Coalition for Health AI, I think it has already 3,000 members. I'm a member of this group. The whole initiation is different groups. They come and develop AI models. And what they do, they just discuss. It's an open discussion forum. There are different toolkits that, kind of Microsoft and Google and IBM have developed. They kind of report what happens next for you. So try to use resources. And good news, if you want to wait forever, yes, FDA have some regulations can help you FDA approved, but might take longer. Depends, and other countries and regions also have their own regulation. But majority of them talks about how much is the risk for patients. Okay, this here is my bonus project. I need to appreciate Dr. Inayati. He's my husband too. So, so we developed an AI echo button. And he's missing this meeting. I was the one that developed the solution. He was the one who deployed it in practice. And we were a little startup in the heart of Mayo Clinic during pandemic when everyone was isolated. We could develop that 4 years ago. This, AI Echo Button won an award and was one of the base for majority of the next initiatives. I want to talk with you about hypertrophic cardiomyopathy. It's a rare heart disease that the first, unfortunately, implication of that is the patient is found dead or, if lucky, in emergency department after sudden cardiac arrest. The patient genetically have this gene, but they don't know it. Just reading their clinical notes is so heartbreaking. You burst to tears really when you see what happens, and just, if the patient, is alive, they would receive this little implantable, like this ICD, like kind of device. It is equivalent to a shocker, gives them shock, and they come back to the life. But they need to have this device first, so it becomes an awkward situation. So how we can recognize the patient have this disease? We noticed there are different data sources you can use, but here I'm focusing on echo because we have 25 years of echo images and reports. And the whole model was focusing on, a kind of different sources. This is a genetic disease, so to confirm that they need to have genetic tests, but how many of you get genetic tests? But majority of people with heart issue, at least they have one echo. So this model was developed on echo measurements, so could diagnose the disease based on their first echo, and could have done that, over 4 or 5 years earlier than the first signals, because this genetic disease happens during their life, and sometimes never happens in, they're lucky. But genetically, it needs to happen, unfortunately, at some part of their life. So we developed this model, 25 years of data. The model was developed, and we put it in EHR. So it was sending back and forth information, input, output from echo. And sonographer was using this ultrasound report, which was giving them a kind of a score, 75% HCM or not, and a little bit of more information about that. Then it was going to the physician, and they sometimes needed to collect more measurements to make sure that this accuracy is correct. And then they go and get the surgery, and that installation will happen. So I want to talk about different sections of the kind of development of any machine learning-based decision support tool. So you have model development first, collect data, data pre-processing, everything. Majority of you very familiar with that. Then implementation, you bring this mini brain, you put it somewhere, some input output with real patient. During the deployment, you need training, who is the user, how you are going to monitor. And the fourth one is the hardest one and the best one. That's where our miracle happens. We were so serious about any feedback we were getting. We were going back and retrain the model. We were going back and retrain model. For me, it took 4 months to develop the model. Took me 2 years to fine-tune it. So I want to mention majority of the work is done in step 4, which nobody is talking about that, but you really need patient, kind of physicians, technicians to advocate, give you feedback, and you need a person sit down and say, why this went wrong, why this patient were not diagnosed. And it made an history for me when I saw the 16-year-old boy just pass by, and I saw him, he went to the echo lab, and they pushed the button, it was saying 75% HCM. Whole sonographer said no. They asked 4 levels, discussed 2 hours, and they said that was an HCM. The guy went and got that ICD. That was the day that made my day. I don't know, I'm a mother, I just imagine that could have been my son. We gave life back to that child. Just because this model did great and was very kind of accurate and still in use. What I want to mention to you is we worked with imbalanced data. Mayo data is so imbalanced. Why? Because we are a referral center. People with complex disease come to our visit, so we are missing healthy patients. So this imbalanced data was an issue for us. Demographic variation, majority of our patients were white, 75% white. And that was really a huge issue, just collecting more people, Black African Americans, such a huge issue, how this imbalanced data can be addressed. Different features, children are very different than adults. You should see that. Oh my gosh, that was a lot of fun talks. We enjoyed that discussions. We took all feedbacks necessary, and we accommodate that. So the study was designed, the performance metrics, these are mainly, there is a paper, if you're interested, you can go and study that. But we just suggested to add certain measurements to the echo, which is strain, which shows the elasticity of the heart. And in just 5 minutes extra examination, they can recognize that kind of disease. There are different ways that you can make this model better. If you are interested in a study about SHAP and Lyme, they make your model explainable. A lot of theory behind that, but these are pretty things. I want to just show you how simple is this in practice. It gives a number like 98% and tells what are the measurements need to be added. Very simple design. Physicians liked it, and they just run this for any patients they had some suspicion. So behind the scene, different models are working, but the visualization was very simple. Okay, if you're interested, you can simply go and kind of study these papers. More papers are coming, and we were so proud of that. So last, responsible AI is just ensuring safe, reliable, and fair healthcare AI. If I want to have one line of recommendation to anyone, there is no difference between a good human and a reliable AI. If you are authentic, if you are mindful, and you are doing that with all your heart, your AI is reliable. That's all. Thank you so much.
Awesome. We'll take some questions at this time.
Thank you so much for the speech. My question is, how much So when we go to doctor, how many of the physicians have some kind of AI assistance today? Would you know?
Beautiful question. The whole journey started 7 years ago when I got hired. I got hired to be an AI scientist for the team, but literally all I was doing was collecting information and data and bringing up dashboards. And I was like literally crying for 8 months that I can do more. So they are getting better. Behind the scene, we have several, like a kind of, I should say over hundreds of tools are experimenting. How many of them have FDA approved? How many of them, like literally, but inside Mayo, we have tons of those. The focus is radiology and cardiovascular department for now, but last 2 years, oh my gosh, I don't know. I'm telling you, 60 companies so far I have mentored, and they are all externals. And forget about the ones who are like internal groups. Yep. Good question.
Hi, this is not a question, but you share a link of your paper. So is that in the barcode? Can I get a link of the paper?
The barcode is my LinkedIn, but I'm happy to send you like a kind of, and they are in Google Scholar, happy to send you the link for the papers.
Okay, thank you.
Of course.
Yeah, really enjoy your talk and really glad to see that there have been some like AI-driven model have been implemented. My question is that there are many scholars who are complaining that because when we think about like healthcare context, the interpretability and explainability is very important. And I learned there are two kinds of things. The first one is the model, it is inherently interpretable, maybe like using decision trees model, like more classical machine learning model, but there are also like more advanced models like deep learning model, like black box is very hard to interpret, but many people will use like post hoc to explain it. So like based on your experience, like in which situation, if you will think about to use kind of deep learning model and you will use post hoc explanation to explain the model how it works, so in which moment you think it's okay to go to implement in the real scenario?
Beautiful question. That shows you already have AI experience and you have developed models. So I should say we can have a separate course to deep dive on that. I always say the AI have different levels of like a kind of impressions. One is short term, one is long term. For the short term one, I feel like traditional always work easier. You know why? Why traditional models are easier for the short term? They're easily explainable. Decision-based models. Decision-based, you always understand, okay, girls versus boys, others, heart is the BMI, people BMI more than 30, less than 30. And traditional models embrace that easily because they are decision tree or they're like, they show categories. But when it comes to deep learning, it's so hard to interpret that. So, and not a fun fact, and I need to confess that I had developed over 20 models. I had deep learning, I had tree-based, I had like a kind of generative AI model ones, and traditional model won in short term. Why? Because the physicians endorsed it faster for me, and they could understand that. The disease that I have worked on that is a left ventricular disease, left ventricle of the heart. But I see in my deep learning, it is a right ventricular feature. I show it to physician, nobody endorsed that. Because it's nonsense. In protocol, nobody talks about right ventricular. So what I say, the good or the bad side of like a kind of black box model is when it comes to interpretation, you fail. Maybe it's talking about some dark side of like whole diagnosis error. Sometimes it works, sometimes it not. With Mayo data, I can tell you. So my last recommendation for you is each data has a nature. You should know the nature of that. For Mayo, it's very protocol-based. I should say tree-based model always work better. But maybe for your rural health, a deep learning one more works better. So I would say I don't have a clear answer for that. Beautiful question. If you resolve it, let me know.
I have a question for you.
Of course.
If a health system can only do 3 things this quarter, what would they implement first and why?
Ooh, that's a big question. So first of all, have your own AI committee. Go create an AI committee, a think tank. Pick a computer scientist. Women are amazing in AI. Yeah, sorry, but for some reason, they cordially very well connected, need to be a mixed bag of men, women with different experiences, AI scientists, people with like a kind of mathematic background, clinicians, create an AI governance committee. So try to just bring 3 things on the table. Like what are those like kind of metrics you want to add to your AI reviews? And what are those things you need to be mindful of? So having that think tank, I feel like that's the first step you can do.
I work a little bit more in the data space, so curious about what has been the biggest challenge with data collection for you, and then how would you go about data collection for exploring something in the healthcare space versus actually then needing to implement it later on?
So I'm a fan of data collection because data collection is you pick you pick the things that are important for your AI model. So historically, you would do literature review, you collect your own needs, what data I need, then you come and you collect the data. That's the best case scenario for me. So I know IRB is hard. I know those like patient oh my gosh, that's such a long route. But that's the ideal scenario. Majority of the time I have worked with retrospective data. They are harder because you need to curate it based on your own case, and they have their own biases. But I should say the biggest lesson that I learned is don't dream big. Try to oversimplify. I don't know why AI want to make everything so complex. I always even say the same thing to my startup companies. I know everyone want to send the shuttle to the moon, but you need a tricycle right now. So try to pick the minimum 5 features, stick with those. Don't overcomplex and collect your data with a little bit of. Majority of you are graduate students. You have terminal degree, PhD or so. We used to think complex. We need simplicity for AI, I should say. Good question. I wish that I had a better answer for you.
Hi. So I was wondering, with all of our new technology developing, something that sometimes concerns me in the space is that, for example, not that AI would replace jobs, but this AI might replace it for people with lower income. And what if, do you think the technology, how long we have to sit there that an AI could do a diagnosis, and how we could kind of prevent it maybe, because everyone deserves to have access to a professional that could give more than like a robot to them at this point?
Beautiful question. 4 years ago, when the hype of LLM started, I do remember me and my husband is my long-term colleague. He's a better colleague than a husband. I'm glad he's not here dropping off our son at the school. So I do remember we were like a sleep nest, and we were passing courses, and we were just looking at each other, we all go home, we all will be laid off, because this is a superpower. So we all know that is a threat. One thing that I learned is embrace this journey. And if you want to be on the hype of that and know what happens next and how you should, for example, fine-tune your own skill set, I would say, if you are a creative person, if you are currently here, you survive. Okay? So that guarantees that. But I would say stay away from being traditional or so, that curious mind, asking questions. And don't be scared of this hype. If you still can learn and if still you can, kind of be creative enough, I think you survive. Everything changes. We people even, this is what I heard. Admin stuff, probably they change a lot. And people who are not, you either need to become a good user or you need to become a person who can evaluate those AI tools. If you have either of these skill sets, you survive. Is it better than us? Definitely. We talked about representation bias. Yes, our brains get rewired, probably a lot of biasness. When this hype goes, I don't know. These are, again, chicken situation, but we will see. I feel like that's not a bad thing. Everyone I cannot survive without ChatGPT and Copilot or so anymore. It sounds like I have 4 full-time people working for me 24/7. So I feel like that's a good thing, but we'll see.
We have one online question. Given your data biases that you listed on a previous slide, how did you go about rounding out your training data? So you talked about the biases in the Mayo data set, and they're asking how you went about training that out.
There are different ways that you can reduce biases in your data. About the tools that I introduced, imbalanced data, you can use, do a little bit of a studies in synthetic data, how you're creating synthetic data and dummy data. You can create those. Data have patterns. Unfortunately, certain rare cases, you see that in your data because there are not too many. You can get those. For example, I noticed, for example, that for certain BMIs, I didn't have so many patients, but for example, their representation was just 5 out of 14,000 patients. So we studied their patterns and it kind of regenerated data. So it kind of tried to add more genres, and synthetic data was very helpful. So those patterns can be recognized, and you can create patients, kind of like dummy patients that can help you. Mathematics and theory can help you. Go back to your books that you read 10 years ago and you hate them. All of them are going to help you.
Awesome. Thank you, Dr. Farahani, for that fantastic presentation. Let's give her a round of applause.